Good afternoon and welcome to the Department of Behavioral Health Weekly Update for March 16th. It's almost St. Patrick's Day. All right, it is Women's History Month. That continues, and a quick reminder that we have a couple of events happening in each of the next 2 Fridays. So please access our Facebook page for some panel discussions around women in behavioral health. A reminder also that March is Social Worker Month and our social workers are essential. All right, COVID numbers. We now are over 120 million cases of COVID and over 2.6 million deaths worldwide. In the United States, we are now approaching 30 million cases of COVID and we have over 536,000 deaths. In California, we are over 3.5 million cases and over, over 55,000 deaths. We have a different way of setting this up, and now apparently I can no longer read it. Anyhow, in terms of cases, I just want to, on this slide in Fresno County, we have kind of a few different data sources that have some discrepancies in cases. You'll see on this slide 97,520 cases and 14,096 deaths. But if you go on the Fresno County website, it shows fewer cases but more deaths. The Fresno County website is accurate with deaths. It takes a while for deaths to catch up at the state level, and the state is more accurate on cases. So it's an example where the data has a timing issue. In terms of hospitalization, we're continuing to see that trend improve. We now have 125 people hospitalized in Fresno and only 31 in the ICU, so that's really great news. That number has steadily declined and is much, much better. In terms of the tier, however, we have the stubborn situation where we just can't get under on the cases per 100,000. They've slightly adjusted it now. They'll give you a little bit of leeway if you get under 10, but we are still at 11.9. We're down on the percentage. We're at 5.1% positivity, which is great. But we've still got a little work to do on the number of cases. In terms of vaccinations, we're now over 262 vaccines delivered across the county, which is fantastic. That's about 40,000 more than last week, which is great news. And of those, and remember this slide's a little older than the last slide, so it's not quite as accurate, but you can see here that almost 100,000 people have been partially vaccinated and over 65,000 people have been fully vaccinated. So we're now over 20% of our population getting some degree of vaccination. All right. In terms of the vaccines for the people we serve, our clinic at Pathways will start tomorrow. That will be utilizing a reminder, the Johnson & Johnson 1-dose vaccine. That will go from Wednesday through Friday of this week and likely a similar schedule next week. If you have anyone you're working with in the system as a client of ours, you can email DBHVax to get them registered. They may also access the vaccine at any open clinic. And open clinics are clinics like what's at the fairgrounds, what's being offered through the COVID Equity Project, etc. And we will have some outreach in rural clinics as well. OptumServe will be doing some rural clinics, and we'll be prioritizing the Johnson & Johnson vaccine at those clinics for specialty populations such as the people we serve. Just a reminder that at our clinic, we're not offering the vaccine to family, friend, and caregivers. They need to go through the open clinics. This is just for the people we serve. And for any staff who remain needing to be vaccinated, you may also go to an open clinic to get vaccinated. All right. In terms of an update, there's always different information floating around, so today I wanted to focus on a couple of articles that I read. One is on the AstraZeneca vaccine. The AstraZeneca vaccine has not been approved in the United States yet, but it is being used in a number of other countries. And recently there were some reports of individuals who'd had the vaccine developing blood clots or having abnormal bleeding, and a few people have even died. In fact, in Norway, 4 people died, a woman in Denmark died, and a man in Italy. Anytime there are deaths associated with people after they've been vaccinated, oftentimes people become convinced that it was the vaccine that caused the death. So I want to talk a little bit about AstraZeneca in particular, because a number of experts have weighed in, and I think it's worthwhile to understand, because when you hear, wow, some people got vaccinated and they died, it's easy to make what we call a causal relationship, that they got the vaccine and it caused their death, as opposed to a correlation. They happened to get the vaccine around the time that they developed a medical condition that ultimately killed them. So I wanted to talk a little bit about the United States and our incidence of blood clot. So in the United States, every year, without vaccinations or any other issues, about 300,000 to 600,000 people develop blood clots. It just happens. It can be as a result of a heart condition, an issue with blood pressure, et cetera, but about 300,000 to 600,000 people develop blood clots each year. So that's about 1,000 to 2,000 people a day. And then if 1% of the population who's eligible for vaccines, and there's about 253 million adults in the United States, is getting vaccinated each day, and that's about right now, then you would expect that in that population, that 1% of the 253 who've gotten vaccinated, 10 to 20 people of that number would develop blood clots. Not because of the vaccine, that's just the incidence of blood clots in that population. And furthermore, some of the conditions that people normally develop blood clots with are included in that group where they are high risk, and so they're getting vaccinated at an even higher rate. So we would expect 10 to 20 people who are getting vaccinated every day to develop blood clots, not because of the vaccination, but that's the incidence of blood clots in the United States. And so that just gives you an example of some health conditions happen regardless of whether you got vaccinated or not. We're going to expect people to get blood clots, and some of those people will die every single day. And it just so happens that some of those people will have gotten vaccinated. So that's just an example of how when we hear about these things, we really need to have science and research tell us what the truth is, to really investigate and understand, is that incidence of blood clot higher than what we would expect in the general population? And it kind of goes back to what I talked about last week when we talked about that control population and the research. Is the incidence in the two populations what you would expect, or is it more? All right. One other thing that has been written about that I thought was really interesting is they're now looking at whether or not the variants are actually developing in populations that have what we call immune compromised. So they're looking at people really who have cancer or other health conditions where their immune system is not working right. Most people who get COVID have what we call active disease for around 7 days. And we know with coronaviruses that they just naturally mutate. All viruses naturally mutate. Some mutations happen every time it replicates. Most of the time, those are insignificant, transient mutations. They don't have any impact on the lethality of the disease or how infectious the disease is. And so during the time someone has an active infection, that 1 week time frame, really no more than one mutation can occur. But they found with some of the variants that a whole bunch of mutations appear to have occurred all at once. So from one person getting it to when they detect it in the person that infected them, they're finding a lot of variation. And what they think happens is that individuals who are immune compromised have they have an active disease period of time that perhaps is much longer, as long as several months of active disease. Low level, not super sick, but low level. And so that replication is continuing during that whole time, and the incidence of mutation is higher. And so they're really looking closely at that population. And what it really is leading them to believe is it's ever more important to vaccinate people with those underlying health conditions, particularly those that might compromise your immune system, because we don't want you to get COVID. If you have immune compromise, you're more likely to get sick with COVID and possibly die or be hospitalized or die. And you might have a low-level degree of COVID for a long time and kind of incubate mutations. And so I thought that was a really interesting article as we've learned more and more about this concept of viruses that mutate. All right, that's my vaccine update. Let's see. I have a question that I'm going to answer now. Can a Cmhs register a youth for vaccine if they're not assigned to a clinician doctor yet? Remember that the vaccine right now, the Johnson & Johnson vaccine that's being offered, is only for individuals 18 and over. And so we can't register youth if they're younger than that. But if they're 18 or over and you're trying to register them, just email DBHVax and they'll assist you in that process. Okay. So I wanted to go into a little more detail about what we plan to do before a return to work happens. And really what we're looking at is balancing the needs of the people we serve for services to be rendered in person, and also ensuring a safe work environment. And so what's happening right now, some of this already happened, is really a clinical review of the need for in-person capacity. So how much capacity do we need to be able to accommodate people to be seen in person? And so that's looking at them from a medical perspective. We've known throughout COVID that people have to come in and get injectable medication or lab draws, that type of thing. Therapeutically, we know some people don't have the proper equipment or private space at home to have an effective or comfortable setting for telehealth or telephone services. Some people get into crisis or they just need that type of in-person services. And then clients have a preference, and we want to honor that preference. If they want telehealth or telephone, that's great, but if they want in person, we want to offer that as well. And then just an administrative review overall of the need for staff to be on campus. Some work can be done effectively via telehealth, we think, but some really needs to be in person. So that's part of the review that's going on. And then we really have to look at our work settings. We have to look at our HVAC systems, that's the heating and ventilation and air conditioning systems that we have in each of our buildings, and the type of air filters and such, because the CDC has made recommendations and we believe all of them have been upgraded, but we'll keep on top of that. Also looking at room sizes and configurations, including workstations. So how many people typically have been in that room? Is that a safe number given what we know about COVID now? And also in-room ventilation. Can a window be cracked? Could we put a HEPA air filter or HEPA air handling portable unit in a room? And also looking at masks and our infection control practices and physical spacing. All of those things have to be taken into consideration. And really what we're envisioning is, a form that gets placed outside each room, stating what the restrictions are on that room and what measures have been taken for that. And so that work is ongoing right now. We're really getting into it in earnest. And so you shouldn't expect us to return to work until that work has been done in any sort of broad, wide-scale way. And so we'll continue to watch what tier we're in, the COVID volumes, that variant activity we talked about, and our vaccination rates. I will remind you again, please continue to get tested. It's super important, particularly with those metrics that we're looking at, that we have an accurate idea of the amount of COVID within the community, and we won't know that unless that testing occurs. So I'm going to go to questions, and I don't see any questions right now. I'm going to see if there's any on my phone. I don't see any. Do you, Brian?
Yes, there is one.
Okay.
One class.
Hold on, please. Can you read it, Brian?
Yeah, 1 second.
My apologies. A little technical difficulties.
I thought the rate of blood clots have increased since the pandemic, since people are moving around less. Would that be a factor?
So the question is that has the rate of blood clots increased with the pandemic from people moving around less? I haven't read anything about that, but we do know that for certain people with underlying health conditions, their level of activity can impact blood clots. There's a lot of things that can impact blood clots. If you have trauma, you can have blood clots. If you've had surgery, if you've been laying in bed for a long time, you could be more prone to blood clots. Certainly a lack of activity. We know that sometimes people who've been in seated positions, like on an airplane, or it's happened even with some of our military in small confined spaces, if they stay in that position for a long period of time, you can develop blood clots. So I wouldn't be surprised if people who were sitting a lot more than they normally did, or in fixed positions, that we might have an increased incidence of blood clots, but I haven't read anything that has a study about that. Was there any others?
No, that's all.
That's it. Okay. So I do want to let you know that I'm taking a small vacation next week, so we won't be having an update next week. I don't know what you'll do without me. I'm sure you'll be fine, and I'm sure I'll have lots of extra information the following week. So come prepared with your questions. We'll cross our fingers and say our prayers that we get those case rates down, and that we can get out of this purple tier and into the red tier. And please be safe, take care of yourselves, and I'll see you in a couple of weeks.